Good afternoon to you all. Topic for today's class is on aggressive periodontitis. So in this topic, we'll be dealing under the following headings about introduction for aggressive periodontitis, historical background, the diagnostic criteria for aggressive periodontitis, what are the clinical features, how do you classify aggressive periodontitis, risk factors, and on diagnosis and management of the same. So we all know periodontitis is an infectious disease or inflammatory disease of the supporting structures of the tooth, which can cause tooth mobility, bone loss, etc. Similarly, aggressive periodontitis is a form of periodontal disease, more commonly seen in younger individuals that's less than 35 years of age. So how did this term aggressive periodontitis come? So we'll just move on to history about the same. Initially, the term was coined by Gottlieb as a condition called as diffuse atrophy of the bone. Later, Van and Matcher described it as a disease affecting incisors and molars and called it as periodontitis marginalis progressiva. Later, the term juvenile periodontitis was coined by Chadwick, and finally in 1999, World Workshop on Periodontics given the term aggressive periodontitis as the nature of the disease is rapidly progressing. So what is aggressive periodontitis? The definition says that the disease of periodontium occurring in an adolescent, very healthy adolescent, characterized by rapid loss of alveolar bone involving one or more deep or permanent emission. So how do you characterize or what are the characteristic features of aggressive periodontitis? First is the rapid nature of disease progression in an otherwise healthy adolescent, absence of local factors, that is plaque and callus, and presence of familial aggregation of the disease. So how to distinguish between aggressive and chronic periodontitis? Aggressive has a rapid progression, as we have told. Chronic has a slow rate of disease progression. Familial aggregation is very typical in aggressive, and chronic may or may not have familial aggregation. Presence of local factors, very minimal, but the maximum amount of destruction, whereas for chronic, the amount of tissue destruction is commensurate with the amount of local factors. Coming to the age, as we have told, aggressive affects less than 35 years of age, but chronic periodontitis is seen more than 35, that is an elderly individual. So what are the diagnostic criteria? We have primary and secondary features for aggressive periodontitis. Primary, as we have told, the rapid nature of attachment loss and bone loss. So otherwise healthy adolescent or individual and presence of familial aggregation. Secondarily, the presence of a microorganism called as AA, this aggregative bacter, Actinomycin comitans, and some amount of P. gingivalis. Then a defect in the immunology, that is neutrophil dysfunction, a self-limiting nature of the disease. So what we've already explained is being given in the picture. We can see the clinical findings, the nature of the disease. So to classify, aggressive periodontitis can be of two types, localized or generalized. So how to distinguish between the same? Localized aggressive periodontitis, as the name indicates, it is involving less than or equal to 2 teeth, that is incisors and molars, and generalized not more than 3 teeth other than incisors and molars. That is the first difference. Secondly, the age of onset circumpubertal in case of localized aggressive, whereas generalized aggressive can occur even in an elderly individual. The antibody response will be robust or very abrupt, whereas poor antibody response in generalized aggressive periodontitis. So coming to localized in detail. So as we have said, less than or equal to 2 teeth, that is molars and incisors. And why is it localized? What are the reasons for that? We all know incisors and molars are the first teeth to erupt in the oral cavity. So the initial colonization of this particular microorganism in the permanent teeth, after which the body's host response acts against the microorganism, preventing its further colonization on other sides. That is one reason. Secondly, the bacteria which is antagonist to AA can colonize the periodontal tissue and inhibit the further spread of disease, a defect in the cementum formation. Radiographically, we see vertical bone loss. We call it as an arc-shaped defect or mirror image pattern of disease that is involving the distal aspect of the second premolar to the mesial aspect of the second molar. That is seen in the radiograph which is shown below. Coming to generalized aggressive periodontitis, as we have said, it is generalized, that is not more than 3 teeth other than first molars and incisors. So the generalized aggressive disease has 2 types of gingival tissue response. The first one could be a severe acutely inflamed gingiva, which is ulcerated, fiery red in appearance and bleeds spontaneously. Secondly, the tissue can also be pink, firm, which is free of inflammation with some amount of stiffening. The picture shows the two types of gingival tissue response in generalized aggressive. The first one shows the reddish or thickened gingival tissue. Second one is a firm and pink gingival tissue. Radiographic findings in generalized aggressive, as the name indicates, there will be generalized bone loss from horizontal to vertical defects involving almost all the teeth, that is molars, insides, and even premolars in part. We can appreciate that the OPG is shown below. Coming to the risk factors. For aggressive periodontitis, we have microbiological risk factors, as you told, the role of AA and other microorganisms. Immunological, that is related to the immune function, the mucosal defects. Then genetic risk factors, that is the role of gene polymorphisms. And environmental risk factor, where we consider smoking as an environmental risk factor for aggressive periodontitis. Now, how do you diagnose? As we all know, diagnosis of periodontitis is initially by probing. So similarly, in aggressive periodontitis, we can access the deep periodontal pockets, more commonly in the incisors and molar region. Then secondarily, using radiograph, presence of vertical or associated bone loss. Then we can do routine screening using periodontal screening and recording indexes, attachment loss, etc. All these radiographs are taken to confirm the diagnosis based on clinical findings. Coming to the treatment depends on the clinical findings. Initially, scaling and root training can be done in phase 1 therapy. And anti-infective therapy, that is prescription of antibiotics. Antibiotics can be used, that is augmentin, that is moxilin and clavulanic acid. Role of metronidazole against obligate anaerobes. Ciprofloxacin antibiotic, which is effective against all strains of AA, can be given. Always antibiotics are prescribed as an adjunct to scaling and root training. Then, as in case of chronic periodontitis, we do a flip surgery with attempted regeneration of the sites of periodontal intrabony defects. And in advanced cases, patients can be kept under maintenance. So during maintenance phase, utmost care has to be taken for self-oral hygiene measures, that is gap control measures, to prevent the further attachment loss and bone loss. Supportive periodontal therapy includes regular assessment of periodontal parameters once in every 3 months in the first year. So this is about antibiotics being prescribed, which is given in the phase 1 therapy. And in case of advanced tooth mobility, where tooth has to be extracted, we can place implants when the disease activity has been controlled. So to summarize, aggressive periodontitis, as we have said, can affect younger individuals, especially with localized aggressive periodontitis. And the patients may be systemically healthy without any systemic conditions, as in case of chronic. And the nature of the disease is rapid progression in presence of minimal local factors and maximum destruction. It can be localized and generalized. AA is the predominant culprit of aggressive periodontitis, and the role of risk factors, that is microbiological, immunological, genetic, and environmental risk factors. Thank you.